Hi, Alki Soltis here, and today I'd like to deliver a lecture on optimizing the surgical field in sinus surgery. Now, bleeding is cited by surgeons as the number one reason for complications. A poor surgical field makes anatomy often unclear and can lead to not only intraoperative complications, but poor tissue healing following surgery and worse postoperative outcomes. In litigation reports, it's cited as the number one reason for complications. When performing surgery, we really want to show you how to achieve a field on the right. Here we can see that there is very little mucosal oozing, and as a consequence, surgery can progress more safely, at a quicker speed, and with more intricacy and meticulous nature, and allow for safer surgery with better outcomes. In the next 15 minutes, I'd like to speak to you about important preoperative considerations in improving your surgical field, how to optimize the surgical field intraoperatively, and how surgical bleeding should be managed at the time of surgery to improve the surgical field. Preoperatively, attention must be paid to hypertension. Patients often have hypertension as a coexisting comorbidity. It is important to ensure that patients have their hypertension well managed and that antihypertensive medications are not erroneously omitted on the day of surgery. This will allow a better control of hypertension intraoperatively and better surgical fields. With the increasing prevalence of obesity, obstructive sleep apnea is another common comorbidity seen in many of our patients. Studies have shown that patients with obstructive sleep apnea have increased mucosal oozing for a number of reasons. Firstly, they have a much higher lability of blood pressure, which is more difficult to control by the anaesthetist at the time of surgery. These patients also have carbon dioxide retention, which leads to local vasodilation and hence poorer surgical fields. A preoperative diagnosis of obstructive sleep apnea should be made if suspected, and all attempts should be undertaken to ensure that the sleep apnea is well managed in the weeks leading up to surgery so that carbon dioxide retention is minimized. Another important preoperative consideration is the presence of coagulation disorders. Now, coagulation disorders can be broadly categorized into congenital issues or into acquired issues. Chronic diseases such as chronic hepatic insufficiency and chronic renal dysfunction can lead to bleeding through multiple different mechanisms. Medications, both prescribed and over-the-counter, also can have significant effects on platelet function and bleeding at the time of surgery. It is really important when speaking with your patients preoperatively to take a thorough history about over-the-counter medications, as often patients ignore to tell their treating physicians about these medications as they have not been prescribed. Fish oil and the medications that commonly start with G are potent causes of intraoperative bleeding. Generally, if possible, I advise that all patients stop any over-the-counter supplement for at least 10 days prior to surgery. Now, attempts have been made to determine protocols that will allow a surgeon to work their patients up according to their bleeding risk. This protocol, published in 2016, asks questions about a patient's previous bleeding history, whether or not they've had prior exposure to a hemostatic risk, if they will be undergoing significant surgery at the time of surgery, and whether or not the surgeon has concerns about the surgeon's bleeding history. According to the answers provided to these questions, The authors of this document have stratified what testing needs to be performed, as you can see outlined in the table here. The reference for this article is provided below, and I would recommend reading this in further detail. Preoperatively, double-blind, placebo-controlled, randomized controlled trials have shown that steroids do improve surgical fields. This is particularly relevant for patients with high disease load and nasal polyposis. In this study of patients with nasal polyposis undergoing endoscopic sinus surgery, a 2-week course of prednisolone was correlated to a much better surgical field and lower intraoperative blood loss. A similar randomized controlled trial looking at the administration of intranasal corticosteroids for 4 weeks prior to surgery showed similar benefit of steroids in terms of surgical fields. The latter is important as a significant study, as often patients will discontinue their intranasal corticosteroids prior to surgery as they do not feel it confers a symptomatic benefit. I generally advise my patients to keep on these medications right up until the day of surgery to improve their surgical fields. Now, the mechanism of steroid action in improving hemostasis remains unknown, but it's thought to be in part secondary to the anti-inflammatory action of steroids and the reduction in the release of vasoactive peptides from inflamed tissue, but also thought to be in part due to the synergism that steroids have with local anesthetic medications. It is thought that steroids potentiate the action of local anesthetic agents on the alpha-1 adrenoreceptors, and in doing so, ensure better vasoconstriction at the surgical site. Now, there are significant intraoperative considerations that should be carefully looked at prior to surgery. I will speak to you about ideal positioning, which anesthetic method seems more favourable, what local measures can be undertaken, and how meticulous surgical technique can lead to less intraoperative bleeding as well. Now, studies have shown that reverse Trendelenburg between 10 to 20 degrees significantly improves surgical field without compromising intracerebral blood flow. It is often difficult to guesstimate the degree of reverse Trendelenburg, and so when starting out to perform sinus surgery, I would recommend physically measuring this angle using an inclimeter, which is commonly found on most new smart devices. This will ensure that adequate reverse Trendelenburg has been achieved prior to surgery. On this point, it is important that reverse Trendelenburg rather than head up is how the patient is being positioned, as head up does not result in venous drainage to the legs. It does increase intrathoracic venous congestion, and as a consequence, there is more blood that pools at the sinus surgical site than it does in the legs in patients with reverse Trendelenburg. Another word of caution is to avoid too much head up, particularly in the elderly. Studies have shown that if an angle of 30 degrees of reverse Trendelenburg is used, intracerebral perfusion can drop significantly. And in predisposed individuals with poor circulation, this can result in stroke and even death. Ideally, if we can deliver controlled hypertension, we're more likely to get a better surgical field for our patients. Controlled hypertension is defined as a pharmacological reduction of mean arterial pressure to less than 70 millimeters of mercury. A patient's age and comorbidities certainly need to be taken when trying to achieve such a low mean arterial blood pressure. This graph, taken from a publication in our department, shows the very nice correlation between bleeding score, represented by the red line on the graph, and mean arterial pressure, represented by the blue line. We can see that as mean arterial blood pressure increases, the bleeding score also increases. And as the score decreases, particularly below the magic mark of 70 millimeters of mercury, bleeding score drops significantly. The way that the anaesthetic is administered is also important. Generally, laryngeal masks are favoured over endotracheal tubes for the following reasons. There is less stimulation when they are inserted and in place than an endotracheal tube going through the vocal cords. It also allows for faster controlled hypertension without the spikes in blood pressure that typically occur during intubation. As the tube is not irritating the larynx, you can avoid muscle relaxation. A smoother wake-up is much more possible with a laryngeal mask than it is with an endotracheal tube, and this translates to less coughing on emergence and less bleeding. And finally, the glottis can be protected at the time of surgery. Now, a laryngeal mask does not reduce post-operative nasal bleeding once the surgery has been performed, and this study demonstrated this nicely. Now, the way that surgery is performed or the anaesthetic is delivered can be controversial, with much contention between anaesthetists and surgeons. Inhalational anaesthetics are often preferred by anaesthetists as they are easier and patients will often emerge quicker from the anaesthetic. Total intravenous anaesthesia, however, has got good evidence to support hemostasis and better surgical fields, but is a lot more time consuming and involves the anaesthetist being more proactive during the anaesthetic. Now, a systematic review and meta-analysis on this topic was published in 2013. This study, done by a group in San Diego, showed that there was no difference between the two groups in terms of the measurable parameters, and as a consequence, they concluded that there was a limited evidence to support total intravenous anaesthesia over inhalational anaesthetics. As a consequence, the anaesthetists often reference this patient when a surgeon asks for total intravenous anaesthesia. Now, in my experience, there are two types of anaesthetists that will use this meta-analysis. The lazy type that will put their feet up and ignore the surgeon, and the aggressive type that doesn't like to have the input of a surgeon into their specialty. So as surgeons, I think we need to be aware of the literature and really carefully look at the paper that is being referenced by these anaesthetists when they argue that there is no difference between the two. And it really comes down to the quality of the papers included in the meta-analysis by de Conde et al. Here we can see that of the 7 papers included, the groups were significantly heterogeneous in terms of size, demographic, and disease status. We can also see that there is a significant absence of recorded data for many of these studies. Disease severity, which is very important and correlates to poor surgical fields, was not complete for at least 4 of the studies, with radiological scores and polyp status not recorded by the authors. In some studies, important parameters such as mean arterial pressure and estimated blood loss were also omitted, as were anaesthetic time and operative time, which makes it very uncertain to me as how these surgeons could come up with a conclusion based on such a poor data set. Now let's look at the 2 different anaesthetic techniques in closer detail. So inhalational anaesthetics, although they can achieve the same blood pressures that total intravenous anaesthetics can, do it by vastly different mechanisms. Inhalational anesthetics cause non-selective vasodilation. In doing so, they also cause a reflex tachycardia. So although the blood pressure often drops, the patient's physiological drive is to increase that blood pressure by increasing the heart rate. If we look at total intravenous anesthesia, it delivers its anesthesia through selective action on the central sympathetic tone. This has no effect on peripheral vasculature and does not lead to vasodilation. There is no reflex tachycardia due to the mild cardiac output suppression effects of the agents. Baseline catecholamines are maintained, as is pre-arteriolar capillary sphincter tone. If we look at surgical grade versus mean arterial blood pressure, we can see the correlation between the two different anesthetic groups nicely. Now the triangle group represents sevoflurane, and here we can see that irrespective of the blood pressure that is being recorded, the surgical grade score is high between 2.5 and 3. If we look at the total intravenous anesthesia scale, however, we can see an almost direct correlation between the mean arterial blood pressure that is being recorded and the surgical grade, so that as the mean arterial blood pressure is being reduced by the anaesthetist, the surgical grade score is also reducing. This is what is important in the surgical field, not the numbers. And that is why I really strongly advise being all over the literature so that you can have these conversations with your anaesthetist if they are disgruntled and do not want to administer total intravenous anesthesia. Now, the ideal mean arterial blood pressure, as we said before, is around 70 millimeters of mercury for the average person undergoing sinus surgery. And the reason for this is that intracerebral perfusion is maintained at this level. Once the mean arterial blood pressure drops below 65 millimeters of mercury, we can see that there's a significant reduction in intracerebral blood flow. And in patients with poor cerebral perfusion or of an older age, this can significantly reduce cerebral perfusion and oxygenation and can lead to post-operative confusion and, in worst case scenarios, stroke or death. Now, obviously, mean arterial blood pressure is very important, but pulse rate and maintaining a relative bradycardia is as equally, if not more, important in achieving an optimal surgical field. Pulse rate not only has a direct influence on mean arterial blood pressure, but it also improves the surgical field through venous return. When the pulse rate reduces, end diastolic filling time increases, and as a consequence, there is more time for blood to be drained from the surgical field back to the heart. The slower the heart rate, the more effective this process, and less blood is in the surgical field to cause mucosal oozing. Now, when we perform surgery, topicalization and preoperative installation of local anesthetic agents is also very important to achieve hemostasis. This is my surgical setup, where we have local anesthetic, which is 2% lignocaine with 1 in 80,000 adrenaline to inject the septum. And we also have a modified Moffitt solution. I typically use 1 in 1,000 adrenaline, 5 to 10 mils of normal saline, and cocaine solution, 5 to 10%, usually 1 to 3 mils, depending on the patient's weight. This is mixed up, and patties or Mericel sponges are used to topicalize the mucosa preoperatively. Here are the ratios of the agents I use. Now, in the United States, when I was performing fellowship, cocaine was not available. In this In these cases, we used 1 in 1,000 to 1 in 10,000 adrenaline. And studies have actually shown that the efficacy is probably very similar between 1 in 1,000 or 1 in 10,000 adrenaline compared to the modified Moffitt solution, and has a lower risk of adverse drug reactions, with particular respect to cardiotoxicity in vulnerable cardiac patients. Now, this study is very important to show that there is an individual reaction to the topicalization that occurs. When using 1 ml of 1 in 1,000 adrenaline, we can see that the vast majority of patients do not get a spike in blood pressure. But there are a group of patients, as represented by the different coloured lines here, that are very sensitive to topicalization, and in these patients you can see an initial spike in blood pressure when the patties are contacting the mucosa. The use of midazolam or other agents can help to, or clonidine, can help to suppress this initial spike that we see. But this does explain why at the beginning of a surgical case, the surgical field is often poorer, and that as the case proceeds, the field improves as the body settles down. Now, injection, in my opinion, is also very important. I typically inject the septum if I'm going to be performing a septoplasty, and I typically place the patties up against the axilla, in the middle meatus, and in the sphenoethmoidal recess, so that I can saturate the mucosa in these areas where the surgery will be performed. I also like to inject the axilla and the head of the middle turbinate, as the middle turbinate is an extremely sensate structure, and manipulation of the middle turbinate in a patient can significantly cause a pain response and an increase in pulse rate and blood pressure. Intraoperatively, saline can be used for a patient who is oozing significantly. Studies have examined the ideal temperature for the saline, and generally it is recommended that hot saline or warm saline should be used. In essence, the temperature of the saline should be around 49 degrees Celsius. This leads to a significant reduction in oozing with no associated tissue necrosis. Once temperatures of the water exceed 52 degrees Celsius, tissue necrosis can occur, and this can lead to poorer post-operative healing and scarring post-surgery. Temperatures below 46 degrees Celsius, although they do have benefit in washing away the vasoactive peptides, have little effect on the mucosal oozing and generally are not as effective as the warmer temperatures. Generally, hot saline is more important in prolonged cases. Here we can see in this video that washing with saline and then being very careful to suction out the blood without contacting the mucosa significantly helps with the oozing so that surgery can be progressed. Now, surgical technique is also very important, and meticulous tissue handling cannot be underestimated. Stripping of mucosa can lead to significant mucosal oozing from the bone, and this oozing is particularly difficult to control and will persist to the point that it can obstruct clear surgical dissection. So if possible, fracturing of the small cellular partitions and preservation of the bone overlying the mucosa should be attempted in all cases to improve the surgical field and also the post-operative healing. Now, the delivery of precise cautery through bipolar diathermy is also a way of improving surgical fields. Try to avoid monopolar cautery if possible, as this creates a much larger thermal injury that can take a lot longer to heal post-surgery and can lead to secondary bacterial infection in the early post-operative period. Furthermore, monopolar should never be used around critical structures such as the skull base anterior ethmoid artery region or within the sphenoid sinus for fear of transmission to the optic nerve. Here we can see bipolar diathermy on the skull base in the region of the anterior ethmoid artery. And we can see successful control of the mucosal oozing at the time of surgery. This concludes my talk on optimizing the surgical field. Please feel free to follow any of my social media accounts or visit my website, which has videos that demonstrate different surgical procedures and surgical techniques, and a link to these lectures. Thank you for your attention.